Hello, I'm Joe Stefanski, one of the EM residents here at Brookdale, and I will go over some of the aspects of the primary survey in a trauma. The role of the airway physician is talked about in a separate video. Although there is some overlap between the survey physician and the airway physician, this video will focus on the stages after airway is addressed. This is the roles and responsibility sheet for the survey physician that should be included in your orientation materials prior to your rotation here. We will go over the items on this sheet. Every morning, this Mayo tray is stocked by our patient care technicians with general IV materials. Prior to your shift, please familiarize yourself with what is on there. If the traditional peripheral IV cannot be obtained, you have several additional options. You can obtain a peripheral IV with the ultrasound. You can see we have these longer gauge IVs that are stocked in the back glass cabinets and can be helpful for reaching deeper veins. You can place an intraosseous or IO needle. As I open this up, you can see we have several IO sizes. We have videos on our website on how to place an IO. You can also place a central venous catheter, also known as a central line. Two of the more common central line catheters are a triple lumen and a percutaneous sheath, commonly known as a cordis. You can place a central line in a few anatomical locations, which include the internal jugular vein, subclavian vein, and femoral vein. Videos on how to place a central line can also be found on our website. The second step of the primary survey is assessment of breathing. Relevant vital signs include oxygen saturation and respiratory rate. To assess the patient's breathing, the survey physician must expose the patient's chest, visualize respiratory effort, visualize chest rise, whether it is symmetric versus asymmetric, palpate the entire chest wall for crepitus, and auscultate the lungs to assess for breath sounds bilaterally. As a survey physician, your primary intervention for B would be to decompress the lung if you suspect or have a confirmed pneumothorax, including tension and hemothorax. The trauma bay should be stocked each shift with supplies you would need to place a chest tube. This includes varying chest tube sizes, chest tube insertion trays, kits, and Pleurovac. This chest tube cart can conveniently hold those supplies bedside for you while you perform the procedure. The third step of the primary survey is the assessment of circulation. Relevant vital signs include heart rate and blood pressure. The assessment of circulation includes evaluating the general appearance of the patient to assess for pallor and cyanosis, feel the patient's skin for warmth, and palpating distal pulses. There are several causes of shock that can occur as a result of trauma, but we will focus primarily on hypovolemic hemorrhagic shock and obstructive. The two major causes of traumatic obstructive shock include tension pneumothorax, which we addressed in breathing, and cardiac tamponade. Tamponade should be heavily considered in patients who have penetrating injuries to the chest, especially around the heart. The traditional assessment of tamponade is Beck's triad of hypotension, muffled heart sounds, and JVD. In recent years, ultrasound has been a helpful tool to diagnose tamponade by identifying the presence of sonographic pericardial effusion. If tamponade is confirmed, the treatment is a thoracotomy with myocardial repair. If the patient has a palpable pulse, the patient should be transported to the OR emergently. If the patient is unstable or has no pulse, a thoracotomy may need to be performed in the ED. Videos detailing the procedure can be found on our website. Next, you want to assess for areas and compartments where a patient may hemorrhage from. Hemothorax was addressed in our previous section on breathing. Assess for hemoperitoneum by visualizing the skin overlying the abdomen and palpating for peritonitis. The fast ultrasound exam can assess for free fluid. Assess for retroperitoneal bleeding from a pelvic fracture by rocking the pelvis. Certain pelvic fractures may benefit from a placement of a pelvic binder. Videos on how to place a pelvic binder can be found on our website. Patients can hemorrhage into their thighs, especially with displaced femur fractures. Visualize and palpate the femurs for deformities. Straightening the thigh and the application of a hair traction splint may help minimize hemorrhage. Distal extremity hemorrhage, including from amputations, may benefit from the application of a tourniquet. Areas not amenable to tourniquets can be treated with direct pressure, staples, and sutures.
Hello, I'm Alex Chasen, and I'm going to go over the rest of the primary survey. The next step is to assess for D or disability. Two major categories of injury in regards to D include traumatic brain injury and spinal cord injury. The evaluation for traumatic brain injury, or TBI, is often initiated by the airway physician who is at the head of the bed and can note such findings as external head trauma, pupil size, and the GCS. If this has not occurred yet by the time D is to be performed, then the survey or airway physician can do it now. Patients with high suspicion for severe TBI may benefit from mannitol or hypertonic saline, both medications that may reduce intracranial pressure and can be started empirically prior to confirmatory imaging studies. Spinal cord injury can be evaluated for by checking distal motor and sensation. If the patient is awake, you can have them squeeze your fingers or wiggle their toes. If the cervical spine cannot be cleared of injury using a clinical assessment tool such as Nexus or the Canadian C-spine rule, then protection by placing a hard C-collar is appropriate. The patient should then be turned with protecting the C-spine at all times. The cervical, thoracic, and lumbar spine can be palpated for tenderness, step-off, or deformity. At this time, it is also appropriate to check rectal tone, for which you can check the tone and see if any gross blood. The next step is E for exposure. This is often performed in conjunction with D disability when the patient is turned to the side. Remove all clothes if not already done. Carefully examine each area of the skin, including occasionally missed areas such as the axilla. Once complete, cover the patient with ideally a warm blanket and gown to prevent hypothermia. The next step is F, which can stand for fast, fingerstick, and Foley. If the fast exam has not already been done, one should perform it now for patients with significant blunt trauma or penetrating trauma to the torso. Videos on how to properly do a fast exam can be found on our website. Obtaining a fingerstick value can also be important in patients who arrive altered. Placement of a Foley catheter can be helpful in major trauma patients in order to monitor urine output. This can also be a helpful reminder to check the genitals for signs of trauma, such as blood at the tip of the meatus. If your patient is a female of reproductive age, this may be a good time to get a urine pregnancy test, especially if patients are altered and cannot tell you if she is pregnant or not. Adjunctive tests may be helpful as part of the primary survey. These commonly include chest x-ray, pelvis x-ray, and an EKG when appropriate. Now, let's go over some additional tips regarding the primary survey. For rapid completion of the primary survey, more than one physician can be utilized. For example, if the patient has a large pneumothorax, one physician can place a chest tube while the other completes the rest of the survey. If the patient deteriorates, it may be prudent to reassess by performing the primary survey over again, starting with A. The secondary survey should only occur after the primary survey is completed and the patient is stabilized. We hope you enjoyed this video. Please check out our website for additional instructional videos.